présentation ici, et donc ça passera en mode présentateur.
Oui.
Puis pour changer, ce sera droite, gauche, et pour
D'accord.
pointer, ce sera le bouton
Ah,
milieu.
d'accord. Ok, ça
Et
marche.
puis le micro, c'est juste ne pas. La coupole, c'est pour empêcher de mettre la main ici en dessous.
Ah bon, donc on doit passer
Il faut le
le
mettre.
cornet de cam.
Ouais, c'est ça.
Ok, c'est
Ah oui, et on fait un live streaming.
bon.
Ça te va?
Oui, bon, bah, pas de souci.
Et c'est donc il faut éviter d'aller trop par là, sinon on a le visage dans le projet. Et
Ah
donc
oui.
rester un
Okay, so let's sit down and let's start this evening. Je voulais démarrer une page, mais je l'ai pas fait, alors j'ai changé d'avis. C'est pour ça que tu fais. Right. Well, very, very warm welcome for you to you all for joining us on this second workshop. One question: who has not been here before? New faces. That's what we like. Just then, a 2-minute introduction to what this building is all about and what we are doing. My name is Philip Van Impe, and I'm part of the data science community. So we've created a community of data science expert, and now we are spreading out that community all around Belgium. So we just created Data Science Liège, Data Science Leuven was created, Data Science Ghent, Data Science Antwerp already exist. So we are active, and I think to stay in the same line, we should create Data Science Brussels as well. So if you want to join us on the creation of Data Science Brussels, I think it will be good. And then we can have Data Science Brussels and then something on top of it to just do the general coordination of everything. So very warm welcome. This place is basically the place of the tech communities of Brussels. It's like a clubhouse. It's your space. It's a space where you go to learn new things, to share what you know, to work on a project. If you are in between two projects and you are a freelancer, just come and sit here. You will probably find another project. Yeah. If you are in between two jobs, you can come here and you probably find another job. If you are in between two technologies and you want to move from BI to artificial intelligence, for example, just follow our different boot camps. We have, for the moment, we are finalizing a blockchain boot camp. We will start a data engineering boot camp and then also a data science boot camp. Boot camps are always done in the same way. We start with a long introduction, like a 6 weeks, 7 weeks introduction on coding. So making sure that the people have the technical skills to then move on to a part which is only business, where some people are coming from the business and say, this is my business problem, and this is how we solve this business problem. Let's look at the data together. This is my code. I'm sharing it with you in my GitHub, and things like that. Yeah. But first, you have to go through the necessary certification. If you go for data science, then you will probably get certified in R, in Python. You will have to show that you know some SQL, and then you will also learn new technologies that are more for streaming data. That could be interesting. Yeah. Maybe we do Scala this year. We're not 100% sure because I like in between if we do Scala or not. So that's what we do. We make sure that knowledge can be transferred. Yeah. Once you've done all the certification, and during the certification you end up in a leaderboard, and basically that leaderboard allows companies to see how good you are and to recruit you. And then basically then from then on you move to a 2-day-a-week exercise for 12 weeks where you get business cases as well. Example of a business case would be DHL, who is doing some logistics optimization of the travel routes for planes, where for the cargo flights, optimization of cargo flights. The flight that go, that's kind of easy. You just push, and when it's full, it's optimized. But it's the return flight that needs to be optimized, and it should not be empty. And that's a whole exercise that these guys are coming to explain. They explain what they've done, an exercise with Fraunhofer in Germany, and it's basically the whole concept that Fraunhofer explained to them that they've implemented, but there's still a lot of room to improve. Why are they here? Why do they want to do that with us? Is because they know that in the room, in the 20 people that will be in that room, there will be somebody who says, why didn't you do it that way, or couldn't you do it that way? And in logistics, an optimization of 0.1% is worth a lot of money. So they're just hoping to have somebody who says, yeah, create another hub. So that's what we do. That's our business. We are financed by the bigger companies. We are financed by the Carrefour. We are financed by Engie. We are financed by Johnson & Johnson. These are the companies who finance us. Yeah. We are also assisted by the region of Brussels. Yeah. They pay our energy, the energy costs of the building, but we get some support from them as well. Yeah. We also have a support from the owner of the building, who gives us. We rented out this building for 9 years. We are here to stay for at least 9 years, and gave us a very good deal on the rental of the building. Yeah. So it's a long-term project. It's about sharing. It's within a community, and here you will meet other communities as well. You will meet communities that are about artificial intelligence, augmented reality. That's what I wanted to say, or virtual reality, or IoT, or even blockchain. Yeah, these people are always here. Once you are here, once you work here regularly, you meet other people. Sometimes you will want to create that company or develop that idea. You will meet somebody and then once you have that idea, we will be there to assist you and to help you with the setting up of your first customer. Yeah, you can go in one of the project pods upstairs, work with your new friend on the project, give yourself a timeline, say, okay, let's do this in 2 months, work like madman. This is open 24 hours by 24 hours. So you work around the clock for 2 months, have your baby ready. We'll help you sell it to the bigger corporations that are sponsoring us, and there you go. You have your startup up and running. Yeah. Now, an exercise that we have been doing for the second time is working on a bigger project, the bigger Data for Good project. Yeah. Some of you were here. Who was here for the dengue hack? Yeah, Cyprien. Annelies was the project manager of the dengue hack, so she can tell you more about it. And you won a prize, yeah. So you were one of the winners for the dengue hack. The idea is you take a life-threatening project that could change the world. Basically, you have to look big. Yeah? You don't do a Data for Good project for something that is not worth it. So you look big, and you work on that project to identify possible solutions. Yeah, Louis is going to talk about the importance of the project, how he thinks it should be done, and what HIV drug resistant is all about. My board will give you even more details on the technicalities of the sickness as well. Yeah, because what you will be looking for is elements that could help you identify those areas that you want to map out. It's this exercise is to map out the areas where there is more drug resistance than in other regions, so that governments, local governments, can impact on that, focus on that area that is more with a higher level of drug resistance. Yeah. The idea is to do the hackathon end of September. The idea is to send the winners to the local countries to use the local data and see, what they have defined works with real data. Yeah, you will have some data here. We'll be working on that, but the ultimate goal is to be able to fly over there, set up a team, train the people there, and start using the data there. Yeah. That's the whole objective. Voila, that's what I wanted to say. I leave you in the very good hands of Louis, who is a project manager. He's working full time on this project. He's eager as can be, and here you are. Thank you, Louis.
Thank you, Philippe. So, good night. Welcome, everybody. I'm going to say a few words on the HIV hack project itself, and then I'll let Jérôme from Dalbert Data Insights make his presentation, followed by Marie-Pierre. So the HIV hack, the goal is to address the problematic of HIV drug resistance. So it's the emergence of resistant viruses in Africa mostly. So HIV-related deaths, HIV infections are going better. It's going better. It's going down. But now we see another trend because we put a lot of people on medication, and in response, we have now more resistant virus. And so this is going up, and this is what we want to fight and find solutions for before it gets too bad. The process of HIV drug resistance will be explained in more detail by Marie-Pierre in the second presentation. So voilà, this is a little word on the HIV hack. I'll tell more about it and on the projects we initiated at the end. And then after that, we will have pizza and we can discuss around your ideas, your propositions, if you have questions for the speakers too. Voilà. So good night, and Jérôme, please, welcome.
Okay. Good evening, everyone. Thank you for being here. So yeah, I'm going to present you some things we can do with telecom data for public health, and hopefully give you some inspiration to use maybe similar methods for the HIV hack, basically. So maybe some of you have already seen me presenting like 2 months ago. So of course there will be a couple of things in common, but I've tried to change everything I could change. So we will go just a bit more technical, and I've also changed the two use cases I'm going to talk about. So hopefully there is new content for everyone. So this is the outline of this presentation. First, just a few words about who is Dalbert Data Insights. Then why telecom data, what is telecom data, what can we extract from it, which could be relevant for public health, three technical tips, and then present you 2 things we've developed, one toolkit and one app for monitoring Zika and dengue in Brazil. So we're Dalbert Data Insights. We're one of the businesses, part of the Dalbert Group, which is a group of businesses active in the developmental sector. And so we are the analytics part of that big group, and we try to leverage public and private data for social impact. And we are active in a range of different fields, like financial inclusion, trying to make sure more and more people get access to basic financial services. Smart cities, so all about mobility, helping public authorities to improve their infrastructure so that people have better mobility in their cities and countries. Public health, which will be what we will be focusing on today, and some agriculture and food security works, trying to predict yields, detect food crisis, and things like that. So, why is telecom data a good source and that we can use in many different use cases? First, nearly everyone has a phone, so we get pretty good representation of the population with telecom data. That data is already collected by operators for billing purposes, so there is no additional cost or infrastructure needed to record that data, store it. It's already there. It's collected in a systematic way, so I mean there is no hand transcription process. It's all automatic, all systematic, all consistent, and we have a good spatial and temporal resolution. So those are the main advantages. Of course, there are drawbacks and limitations. So some groups are not well represented in telecom data, which can introduce biases. Also, in many countries, you have people doing multi-SIMing, so using different operators depending on which activities they want to do or who they want to contact, and so you don't see their all activities basically if you just have data from one operator. It's quite sensitive data, so we have to take steps, and even more now with the GDPR, to make sure that we don't put privacy at risk. It's a very large amount of data, even though right now it's not really a problem anymore, and we have machines to deal with those large quantities of data. And if we go back to temporal and spatial resolution, so the limitation on temporal resolution is that we only have one row in a database when there is actually an activity on the phone. So you make or you receive a phone call, you send or you receive a text, or in some cases when you have some 3G, 4G activities. But like if my phone right now is in my pocket, you wouldn't have any records from me at this moment. So that's a limitation, the temporal resolution. And spatial resolution is limited to tower areas, so it's not as accurate as GPS, for instance. So yeah, those are the limitations. Still, because we have many advantages, still a very good source to use. Not always alone, but it's very informative data. So what actually do we speak about? So the main thing I was referring to is every time you make an activity, we'll get one row in a database, and that is called a call detail record. And you have several fields. You have unique identifier, which can be the phone number or some anonymization of it, of the person who initiated the connection, person who received it, the type, whether it's SMS or voice, the direction, whether it's incoming or outgoing. I'll get back to that a bit later. Some localization information, so which cell was active for that communication, timestamps. In case of voice activities, you can get the duration of the call. We usually get fields about the type of phone, so IMEI is a unique identifier of the phone, and the first 8 digits of it are related to a phone model. So using that, you can know whether the person is using a smartphone or basic phone or whatever. So that's what we get every time there is one activity on the network. So yeah, as you can think, we can do a lot of things with that, and some of those are very useful for public health. So I just listed those I think could be useful here, and we've already used some in our use cases. Other ones could be used maybe for HIV hack. First range of things you can extract is related to mobility. So because we know who was there when, you can kind of track people. You can know which places some people have visited, in general, or you want to focus on overnight trips, for instance, for malaria, because it's transmitted by a mosquito which is active during the night. Or what are the frequent places? You can look at the places of interest, trying to identify the home location of people, the work locations, and maybe some other locations, like they want to go for shopping, for hobbies, whatever you can think of. What are their behaviors, or are there explorers or returners? So do they tend to stick to a few places they visit, or do they visit a lot of different places? Do they move a lot or not? So what is their radius of duration? How far do they usually go? What modes of transportation do they use? What roads do they take? All that can be computed, sometimes not directly, but can be inferred from CDR data. Another range of features is related to social networks and connection people have. So you could try to see if people are well connected or isolated, who is a leader or a follower in a group. That could maybe be useful if you want to do campaigns and you want to target people who you know will have an influence on other people. You could look at the density of their social network, and here social network means people you're connected to. I mean, I'm not speaking about Facebook, Twitter, or whatever. It's really people that you have connections to with your phone. Then you could also look at phone usage patterns. You could track consumption changes, and we've used that for food security, trying to see if there is a drop in phone activity that could indicate people are saving money from their phone because they need more money to buy food. Some other people have shown that actually in other places in the world, you would have people would actually call more some other people when they are in need, because they're just asking for help. And so you could maybe see that in the data and detect that there is a change of behavior that indicates you people are just looking for help, and so that could be useful. And of course, a whole lot of segmentation things you could do. First is, it's binary, who is using internet or not, which also could be useful for some campaigns. Who is using mobile money, but any other thing, like gender, whatever you could think about to segment people. And so it, yeah. Yeah. It depends. It's usually quite narrow, quite dense in cities, and quite broad in the countryside. So, a lot. So it could be in the countryside. It could be 10 kilometers radius, or even more. But in cities, usually it's quite a few hundred meters max, like 50, 100 meters. And so because we can compute all that and many more, this can be useful for public health. One thing is if you look at people's individual mobility, and you know how people move in a country, that's very useful to feed epidemiological models on disease spreading, to trace back the source of an outbreak, and to do some prioritization of hotspots where you want to act on and try to cure and have campaigns. Now, if you look at how different communities are interconnected through phone data, that could help you better localizing health facilities or building meaningful quarantine borders. Finally, by knowing the density of people in the different regions over time, you can better distribute your supplies and help, and you can plan interventions at the right time. So you want to be there at the same time people are there. You don't want to launch campaigns when people have left the place, basically. So those are a range of things telecom data can be useful for. We at Dalberg Data Insights have mainly tackled this, but some other people have done that, and for sure there is room for more than what we do. So now just a few technical tips when dealing with telecom data. The first is I've already shown that structure. I told you I would get back to the direction of the transaction, incoming or outgoing. And usually when you get the raw data, you actually get the location and like the phone type only for one of the two people involved in a transaction. And which one of those will be told by this field, incoming or outgoing. So basically you only get to know those details for the people who are on the network of the mobile phone operator you get the data from. So if you have what we call an on-net call from, so like someone from Proximus calling Proximus, you will actually get two rows in the database, one incoming, one outgoing, right? But if you have Proximus to Mobistar, you only have one, and you'll get those details only for the person from Proximus. So I'm taking the assumptions we have data from Proximus, which is not the case, but yeah, you get the example. So if you want to process that, one practical thing to do is to switch the numbers depending on the direction of the call. So basically, so when there is an incoming call, actually the cell ID and the phone brand, phone type, relate to the person receiving the call. And so what you can do is when there is an incoming call, you just switch those two numbers. And know you'll always have cell ID and phone and maybe some other fields for what is in your column A, and so it's a bit easier to aggregate and to compute locations. And that's actually the base data we use, well, slightly pre-processed because we do that switch for public health and for mobility apps. So it's what we call time positions, and basically it can be as small as 3 columns. So phone numbers are unique identifiers. We don't need to have the actual phone number. Then cell ID, which is the location, and some timestamp, and that's the base of everything I will show you later. Second tip is so those are cell tower areas. Well, so you see the small cell towers, let's say, and then you have what we call Voronoi cells around it. So within each of those cells, so if you take one point there, the closest cell tower is the one that is in the same shape. But of course, that's just mathematical representation. In practice, it's like the coverage areas are not looking like that. It depends on a lot of things, topology, and many different things. And it's pretty hard to get. So we have to make assumptions on like the location of people. And we want to account for that when we try to actually locate people. So one example, if I'm sitting actually there, my call could be relayed by that tower or that tower or that one or that one or that one, or maybe even a bit further because there is overlap in the actual coverage areas. So we try to account for that. And here if we look at the number of activities, so let's say I want to identify the home location of people. So I have summed over 1 month, for instance, all the activities of one person on all those cell towers during the evenings and the weekends. And so I have that for every cell tower, and the maximum activity would be 7 for that one. But that maybe could lead to mistakes, and so one thing we do, and there are other methods to do that, is to actually also account for all the activities in the neighboring cells. And so if we do that and we just sum for every cell, we get different numbers, and then we would assign this as the home location. And in this case, of course, I've designed it so that it makes sense, but you could see there was lots of activity there, while here it's just, it's a lot there, but not a lot really in the surrounding area. So that's just something, there are different ways to account for it. That's one practical way we use, but it's just something to keep in mind is that this is not the actual location. You need to think about overlapping cells, coverage areas, some uncertainty on the exact location, and so you may want to deal with that. And in this example, you could say, okay, it's not far away, but of course you need to scale that to a country, and it could lead to big mistakes if you don't really account for that. And if, like, let's say here we have 4 or 5 different towers that could relay our calls. If they're like evenly distributed, it could be that, you know, I have 5 calls on each tower, and then I'm actually playing football 20 kilometers from here, and it's just always the same tower, and I have 6 activities at that place. And if I just look at that tower alone and not include the neighbors, I would tend to think that I'm living at my football club, which is not the case. So that's one thing to keep in mind. And the last one, yeah, we do have very big computers now, so computing time is not so much of an issue it used to be. But yeah, still it has value to design your code properly. So a ballpark estimate of the quantity of CDRs records we have in developing countries is around 20 per subscriber per day. So yeah, you think about how many million subscribers you have in some countries. You want to track things on maybe months or years. So it can still sum up to a large quantity of data. But fortunately, a lot of computations can be parallelized, because many things you want to do are user related or location related, and so you can just distribute that over different cores thread. I mean, and so you want to make use of that, take that opportunity and design your code smartly to save some computation time. So now moving to 2 things we've developed. The first one is a toolkit to identify gender. So it's not directly related to public health, but I think it may be useful as such, or we could design something similar for HIV hack, like maybe trying to get the age of people, or I mean any other dimension. So what we've done is just classic machine learning problem is try to compute a lot of features from phone usage, relate that to a survey from which we knew the actual gender of 15,000 subscribers, build a model, apply that model to the full subscriber database, and we have over 80% accuracy in predicting gender. Of course, it's a binary product, so it's a binary problem, so yeah, the baseline is 50, we could say, and not exactly like that, because in the country we've done it, there are twice as many men having a phone as women. So, but still, 80 is a quite good number, and is higher than anything else we had seen in the literature. So what we've done, as I said, is a very classic machine learning problem. We've extracted range of features. I've already spoken about a few of those. So some characterizing phone usage, some about mobility, some about social networks. Top up is like when you refill, so you have you put money back on your account, basically, which is happening a lot in developing countries. Many people still use prepaid and not postpaid, as is the vast majority here. And some other features, like if you want to buy a new ringtone, or whether you live in town or in the countryside. So we fed that to machine learning and got this high accuracy of prediction. And so to finish, some words on public, I mean actual public health hub, not gender, which can be used later for public health, but here what we've done on public health, and today I'll focus on Zika and dengue in Brazil. But just to start with a bit of history, so in our group, it started with some use case around Ebola in West Africa. So during the outbreak, we computed mobility matrices to kind of monitor it, and we now have a follow-up project to try to build a tool to ease the monitoring in case such an outbreak would happen in the future, which we don't wish, but we want to be ready if that happens. And not only Ebola, so we want to make that a bit generic, so it could be another disease, and we would have the right tools to deal with it. We now have a project around TB in Gambia, trying to identify hotspots based on mobility from phone data. So I'll speak about Zika and dengue in a minute. And the project I had presented last time was about malaria in Zambia, so trying to identify risk flows and help people on the ground to prioritize directions by telling them, okay, that's an area at risk, and you should go there and try to inform people and spread mosquito nets and everything. So now combating Zika and dengue in Brazil, what data do we use? Well, telecom data, as almost always. Then we also have incidence data, so telling us in each small area how many people are suffering from the disease, so Zika or dengue, and that's refreshed periodically as well. So at least monthly we get new incidence data. And then we have some topology, geographic information, so the population per area, the surface, the square kilometers, precipitation, altitude, etc. So we've taken all that, and our goal was to predict the future incidence of those diseases at each location. And what are the features we use? So it's just past incidence, elevation, some areas, so square kilometers, and population of the place we want to predict the incidence of, but also the 10 places that are the most interconnected with that place, and also the 10 places that have the show the highest importation risk to that place. So this is just looking at mobility. This is combining mobility and incidence from the origin area. And again, we feed that to some machine learning tool, and it gives us prediction. And so this is the range of questions that people on the ground are now able to answer using the tool. So what's the incidence, and what will it be over the next 4 weeks in every region? How many people move? So that's typical mobility. What is the importing and exporting risk in some areas? And you can relate the incidence level with the actions that were taken, because we also get how many actions they've made in each area, and so they can see the relationship between that. And so just now showing you the tool. So that's the main tool. You have an incidence map on the left. You get the past incidence here. You have the predicted incidence over there. And this is the actions they have taken. So they can look at that. So that's for the full area, the full period, and in this case for dengue, but they can change that. So it's an interactive dashboard. They can change the dates. They can click on and focus on one area if they want. And of course that's particularly important for them. And we've shown quite, a very high correlation, so that prediction is quite good. And next they can also yeah, the typical use case for us is to have one server located in that country within the premises of the telecom operator, which we can access remotely. So yeah, we'll have to see how we could use and maybe share that data. I think, you know, like sending the raw data abroad is no go, that's for sure. But maybe we can pre-aggregate some things and then, you know, remove the privacy concerns and make some other things available. So yeah, that's to be discussed. I mean, we don't own the data, of course. We're just users of the data. Yeah. 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 Sure. Yeah, you're right. That's.
Could you repeat the question for the?
Yeah, sure. So the question is there a social bias in the subscribing population to every mobile phone operator? And of course, there is a risk that yes, and we know for a fact that in some countries it is the case. I know, yeah, it used to be the same in Rwanda, where one operator was really had a really high penetration on very low income people. So yes, that's one of the risks, and that's also one of the things you want to make sure of when you use the data, depending on the use cases. If you know your use case will be mainly focused on poor people, yeah, sure. Don't try to use the MNO that just has a high penetration in rich people to derive insights from that. Yeah, some people try to extrapolate what they have to the full population, but you know, for me the risk is always when the data you have is really underrepresented for one population. I mean, how good can you extrapolate to what you're actually missing? If you have no data, you can, yeah, try to reconstruct, but it's not always accurate. Yes.
One last question.
Yeah, so the question is, what I've shown here was in Africa, but there are other countries like Ukraine where there are yeah, diseases and epidemics. So why not focus on those countries? Yeah, I have no answer. I mean, if I would be happy to get data and to play with that. We don't have any restriction to Africa. We have some other projects in South America. We had one project in Bangladesh. So I mean, for us, there is no. We don't want to work only in Africa. It's sure that we do get access to some yeah, African data, and there are many yeah, developing issues there. But it's not. Yeah, if we can get data, sure, it's good for us. Yeah. So that's so. How do we get the data? It's yeah, complex relationship with the mobile phone operator. So it's from experience, it's taking a lot of time to build that, to gain trust, and all that. But yeah, I would be really happy to get in touch with some phone operators in other parts of the world and see if we can, if they're willing to, yeah, give us access to their data.
Thank you, everybody. We'll move on to the next speaker.
Ah bon, mais je n'ai que deux mains. Non, j'ai rien. Je suis en train de- Je vais le mettre ici. désolée, j'ai pas de poche. Pas grave. Okay, so maybe I can start by maybe answering partially the last question about Ukraine. Indeed, we are looking mainly at Africa, and when we launched the project, that's really the region we wanted to address, because that's where the majority of the HIV patients are. And that's where there is absolutely no data available on resistance. But one of the ideas we have is indeed to look into Eastern Europe, and Ukraine is in Eastern Europe, where there is a kind of a more recent epidemic than in West Europe, although the virus has been present for quite some time, but hasn't been reported as heavily as was done in the Western or so-called developed world. And to look into Ukraine and other countries and to see what happened there, and maybe use that to model and predict what is going to happen in Africa. Because we know resistance is going to happen. It happened when we started treating patients in the Western world, and it's already there in Africa. We know it's there, and we just want to know how bad it is, or hopefully not too bad. But I have worked with the HIV virus for over 30 years, and I know what that virus is capable of in terms of resistance. So that's what I want to share with you tonight, is to go a bit more into the virology of the virus and see what is our enemy. And so, first a recap, very basic. AIDS stands for the acquired immunodeficiency syndrome, which is the result of an infection by HIV, the human immunodeficiency virus. And AIDS, the status of AIDS is characterized by opportunistic infections and cancers that are not seen in healthy people, and if untreated, is fatal. HIV is a retrovirus. That means that's a virus which integrates its genetic material into the genetic material of the infected individual. And that means that you cannot get rid of the virus, because if a cell genetic material contains the virus genetic material, when it duplicates, you get two cells with that genetic material, and you cannot get rid of the virus. So the virus resides in what is called CD4 cells, which are key to the good functioning of the immune system. And that what's happening when you get AIDS is that actually HIV destroys your immune system. And HIV is transmitted by blood, and sexual intercourse is not transmitted by mosquitoes, like some people might believe. This is not the case. Just a few basic facts to remember. So if we would say that this is a human being in a test tube, okay? This, what is represented here, is actually this person blood, with in blue the famous CD4 cells. And you see that there are many CD4 cells. Now the infection takes place, and within weeks to months, we can see that the number of CD4 cells have decreased, and that the virus is heavily and happily replicating. Over the course of time, the virus is going to destroy those CD4 cells wherever they are in the body. And if it's not treated, we will end up with AIDS, where there are almost no CD4 cells anymore, and where the patient will die from the opportunistic infections and the cancer. So, hopefully, there is treatment. And the treatment has transformed this acute disease into a chronic disease. What is the purpose of the treatment is to control the virus replication. If the virus cannot replicate, it will not kill the CD4 cells, and the immune system will remain more or less healthy. So that's really the aim. So we want to keep the virus under control, to prevent further damage to the immune system, and also very importantly, to prevent transmission. How do we get there? We get there by using 3 different anti-HIV drugs. A combination of drugs which will bring the levels of the virus in the blood to what we call undetectability. And there are tests, viral load tests, which can measure the number of virus particles in the blood. And by using 3 different anti-HIV drugs with different mechanism of action, we can prevent the appearance of resistance. But very importantly, if we want to succeed to control the virus, the patient has to take the medication every day for the rest of his or her life. And you can already see that that is going to be a problem. I'll come back on that. So this is a bit of virology. This is the replication cycle of the virus. I won't go into the details, but just to show that in the course of the years, there have been inhibitors of this replication that have been identified at different steps in the replication cycle of the virus. And it's by combining drugs from those different classes of inhibitors that we can prevent resistance to occur. If we use only one drug, the virus will be initially inhibited, but then will come back and will be resistant. So we've been very, very, very active on finding new drugs. This is the drugs that have been approved by the European Medicine Agency. So those are the drugs that are available in Europe and are essentially the same in the US. And you can see that there are very different, many different classes, and that in the course of time we have started with monotherapy, and that has led to resistance. Adding new classes of drugs has allowed to do this famous combination therapy, and now what is happening is that people work mostly on treatment simplification, so that patients, instead of having to take 2 handfuls of pills every day, can now take 1 pill once a day. So this is what has happened in the so-called developed world. If we look at the limited, at the low and middle income countries, the treatment options are far less. They are divided essentially in a first line, which represents about 90% of the treated patients. A second line, which represents maybe 10% of the treated patients, and a third line, which is anecdotically present in some countries. Why is that? Well, for the first line, it's a single fixed dose combination, single tablet of 2 classes of 3 drugs. This combination is to be taken once a day, so it's very easy, 1 pill once a day. But it has a low genetic barrier to resistance. So if you miss a few intakes for whatever reason, you might get resistance. The second line is another class of drug plus 2 of this class, but there are no single tablet regimens. So you have already to take multiple tablets, and they come from different manufacturers. And those pills, a treatment costs 3 to 5 times the cost of a first-line regimen. If we go to the third line, we try to find things that can be combined, because in the meantime the virus has become resistant to this, to this, to this. So we try to find something which still works. And the cost is, for many countries, just prohibitive. So what we see in Africa is that in the treatment guidelines, they make provision for first line, for second line to some extent, and some countries just say third line, forget about it. We can't afford it. So essentially, if you compare this with the luxury we have here to be able, if a patient doesn't tolerate a certain regimen, we can put him on another regimen. Here, no choice. You take it or leave it. And we know that those drugs have side effects, which will lead also to probably adherence problems. So this is exactly the vicious circle we're in. If we have poor adherence, we're going to get a treatment failure, which will be measured by a detectable plasma viral load. So we will be able to detect the virus in the blood. That will lead to drug-resistant viruses. That will limit the treatment options, require the use of more cumbersome treatment, and we go back into poor adherence. If already taking one pill once a day was too difficult, it's going to be way more difficult if I have to take 2 or 3 or 5 pills and maybe twice a day. So that's the problem that we encounter. So how, just a couple of slides on virology. So here to depict, you have the virus population in an HIV-infected patient who has never been treated. We apply drug pressure, and the viral load over time decreases to remain undetectable. But you can see that here, in this population, there are already a few viruses which are drug resistant. And that's why we need absolutely to use 3 different drugs. Because the virus might be resistant to one of the 3 drugs, and so the 2 others will maintain that virus under control. Yes?
The reason why the virus has already some drug resistance, is that because the person who they contracted the virus from had drug resistance, or does it naturally occur?
The drug resistance does occur naturally because the virus is a very sloppy virus. When it makes copies of itself, it makes mistakes. And so it makes the mutations which can render it resistant to a drug. But if you use 3 drugs, those viruses will not be able to emerge. But the resistant viruses are just looming around the corner, and if you release the drug pressure, the viral load is going to increase again, and you're going to enrich the virus population into resistant variants. And that's where you get the problem. You can, if the patient is taking the drugs every day and is completely fully compliant, then we know that the virus will be kept under control. And that can remain for years and years and years. Okay?
And even if this patient who is now drug resistant, right, if they have sex with someone else, and that patient gets the red virus, so the resistant one,
Yeah.
if they take medication, can they keep it under control?
Well, it all depends. It all depends on which medication they are going to get, and that's that's just to show you the variability of the virus. This is just one small part of the virus, and every colored dot represents a mutation. And this comes from clinical isolates, and this shows just that you can have billions of variants, which are all different viruses with different mutations who can cause AIDS. So how is the monitoring, and I will come back on your question, how is the monitoring done in low and middle income countries according to the WHO recommendations? When a patient is tested HIV positive and it is decided to start treatment, the patient is put on the first line that I described earlier. The viral load is not measured at that point in time, and there is no resistance testing done because resistance testing is not done. It's just unaffordable. So the patient is put on first line, and 6 months later, a viral load is measured. If the viral load is below a certain threshold, it's a threshold which is higher than the threshold we use in our countries, but virologically it's still very relevant. If the viral load is below that threshold, the patient is continued on first line and comes back 1 year later to get another viral load done. If the viral load is above that threshold, the patient goes into a course of adherence counseling. And 6 to 8 weeks, well, mostly 3 months later, a new viral load is done. If by that time the viral load has gone to below the threshold, then the patient continues on first line. If the viral load remains above that threshold, the patient should be switched on second line. Just to explain the difference with what we do here, when a patient is started on a first-line therapy, we do a viral load and we do a resistance testing, just to be sure that the patient has not been infected with a resistant virus. And we measure the viral load 3 months later. So we know from the baseline viral load and the one we have at 3 months and then at 6 months whether the viral load is going down or not. Here it's just a bit of a guess. If the viral load is still there, is it because the patient is just still going down? We don't know, okay? And the patient is monitored, at least in the beginning, every 3 to 4 months. And as soon as something happens, viral load is repeated within 3-4 weeks. And the resistance testing is done. So we monitor here the patients very closely just to avoid this resistance to occur. Here we can't because there are no means to do it. And so, as you just said, what are the consequences of not monitoring properly the viral load? We have a series here of patients who are HIV infected. They are put on first-line treatment, and in the majority of the cases, those patients get an undetectable viral load, so they are doing well, they can keep on first line, and most importantly, this pregnant woman gives birth to a child which is not infected. Unfortunately, a certain proportion of those patients do develop resistance, and those are going to infect other people with resistant virus, and a pregnant woman will give birth to a child that might be infected with resistant virus. But now, when those patients are diagnosed with HIV, they are going to be put on first line. But we know that this first line is not going to work. But you can't know because no resistance testing has been done. So those patients are going to be kept at least 6 months on a treatment which doesn't work. And the virus is going to build up resistance, so that even when eventually one notices that there is resistance, that the treatment is not working, the virus has become so resistant that it might be difficult for the second line to work properly. So this is really the importance of avoiding resistance. And where did we learn all this? By treating patients here. We know it's like that, and we know that it's going to happen. Okay, so adherence is indeed, you have to take your pill every day. But we know that you can get treatment fatigue. I mean, we do it. How many of us didn't stop a treatment with one or other drug because I feel better? Why should I keep taking those pills? Okay? There are side effects, and that can be different from person to person, but some of those side effects can be quite really challenging. For instance, the first line which is used right now, one of the drugs caused vivid dreams, they say. You could say nightmares. And some people just can't tolerate it, so they're going to stop. And as I said, they feel better, so they feel cured, and why should I keep taking this pill? The access to treatment is very important, and one of the main factors is the drug stockouts. And for this, I will give you an example of a small country in which is within South Africa and which is Lesotho. Lesotho is about the size of Belgium, 2 million inhabitants, 25% are HIV positive. Okay, so Lesotho has been helped quite a lot by PEPFAR, either through CDC or USAID. But in the course of 2016, PEPFAR decided that 5 of the districts that they were supporting in Lesotho, they wouldn't support anymore. So how is this going to be taken care of? That's one aspect. The other aspect is that locally there are a series of NGOs which are taking care of patients. And you have to kind of have those people working together. Well, forget it. I have worked in the pharmaceutical industry. I thought competition was there, very fierce, but I hadn't seen anything about the NGOs yet. It's unbelievable. When I arrived the first time in Lesotho, Partners in Health had just kicked out MSF out of the country. So that means that the people who had been working there, and I have nothing against Partners in Health, but the people who had been working there had all the contacts and the network were just gone and replaced by completely new people who needed to do it. So, and there are so many different actors involved. You have, of course, the government. One of the big players in dispensing treatment are the faith-based organizations who are really treating patients. They are doing a great job in Africa, in different countries. And then you have the NGOs, and then you have whatever. It's really a nightmare. And this is something, and those are all people who are collecting data. And where does that data go? Big question mark. Okay, so other limitations are the distance to the pharmacy and the frequency of refills, for instance. If I have to go every month to collect my pills at the pharmacy, which is 1 day away from my home, I'm going to lose 2 days a month to get my pills, but while I'm getting them, I have no revenue because I can't work. Okay? The stigma is also a very important factor. If someone sees me walking into an HIV clinic, he's got AIDS. And I don't want people to know that. So how do I do that? And then, of course, the fake information and the spread of urban or rural legends, which lead to denial. For instance, one of the main legends in Africa is that if I have, as a male, have sexual intercourse with a virgin, then I will be cured from my virus. Okay? And that is kept alive. And again, we know here that there are also urban legends. And when I talk to teenagers about HIV/AIDS, it's incredible what I hear about how it is spread, and those legends still live. So it's not proper to Africa, but it's a fact. We have to take that into account. And then, last and not least, the access to information, the education level. And when you see 50 patients a day, how much time is left to give them the proper information? There are no or very little human resources. There are almost no physicians, so it all falls back on the nurses. But the nurses can't do everything, so it falls back on community workers, which means that the information and the proper and correct information has to be spread. Who's doing that? So that's those are all. When we say adherence, okay, we tend to say, okay, the guy didn't take his pills. He is the culprit. It's not true. There are a lot of factors that can be taken into account to explain why a patient didn't get the pills. Okay, so finally, when I was still working at Janssen and when we launched this project, those were the parameters that we listed as possible sources to model. Okay, there are some which are very obvious and which can be accessed quite readily. Here, about half of those dropped from the slide. I don't know what happened. But there are a lot of statistics which are published yearly by UNAIDS. The healthcare system, there are some data that can be found. Resistance studies, that's where there is very, very, very little, especially for Africa, because, as I said, resistance testing is just not done. Who is sitting on a lot of data? WHO. But to access data, WHO is sitting on, I don't know if anyone ever succeeded so far. It's very difficult. And then there is another possibility, are the forecasts for the antiretrovirals or for the viral load test consumption and so on, which should be accessed as well. And that's, yes, I think that's about what I wanted to share with you. So, any questions?
Can do maybe 1, 2 questions, and then during the
Yes.
Yeah, just a question. The medicines, the drugs, usually given at the pharmacy, are they given by 10 pills in a tablet, or is it, how does it go usually?
Usually, when the patient is starting, he or she has to come back every month. And then when the physician or the treating people see that the person is compliant and takes the pills, then that can be for longer. But the longest you have is 6 months.
Okay. So there is no specific standard?
No, but it also depends on the stocks you have.
Okay.
That's those pharmacies are, when you look at the hospital pharmacies, you have 90% is antiretrovirals and the rest is for other indications.
Okay, so there is no treatment where you give, for instance, only for 1 month of taking various pills. I mean, you know, from a medication point of view. I mean,
no, it's every day. It's
no, but I mean, if you get your medicines, your
yes.
drugs, usually when you get an ordonnance,
The prescription, yes.
prescription, usually you have it for a standard amount of time or pills. Is it usually for 1 month, or you have to?
As I said, it depends. In the beginning, you have to go every month, and then once you are doing well, you can go less frequently and get more at the same time.
Okay.
And usually, the treatment is free.
So if it's known that the adherence is often due to a lack or the difficulty to get the medicine, why not from the start give for 6 months, for example?
Because it would. The question is, why don't you give for 6 months from day one? Because you want to see the patient again to make sure that the patient takes the pills. So you want him at least in the beginning to see the patient more frequently. Because you do not do viral loads, you want to monitor something at least. And that's why you ask the patient to come more frequently. But now, when patients have been on treatment for quite some time, they can come less frequently, or they can also, and that's what is observed, some patients form a group, a community, and then one of them goes and picks the drugs for the group, and they go each in turn, so they don't have to go every month or every 2 months. But it also depends on the logistics. I mean, the country needs to have enough stock to give for everyone 6 months of pills. That's also a logistics issue.
Now, just a quick question in any case. I'm not at all an expert about all of this. Just, I would like to know a little bit more about the quality of the statistics, about the HIV infection in Africa because, for instance, naively, I expected that everybody is diagnosed to have HIV because a blood sample is taken and so on. What I was told, I don't know if it is reliable or not, is that in many cases, the infection is rather inferred because you have, for instance, a young person who has a certain kind of infection similar to the parasitic infection, and therefore you tend to believe that that person may have HIV. But it's not that every time you have the let's say the smoking gun of a blood test. So I don't know if that is true or it is true for some countries and so on. Just a curiosity.
No, well, there are two parts in your question. Indeed, first of all, to diagnose HIV, you don't need a blood test. You can do it with saliva. That's very easy. And that is what is happening right now, is that because treatment can be also prevention, the countries have decided that they would massively try to detect the HIV patients and get them on treatment. So there are now massive campaigns where people have to go and get regularly detected. Okay, and once a first test, the test takes 10 to 15 minutes. Okay, and then if the test is positive, then there is a confirmation test. And if that confirmation is positive, then the patient is started on treatment as soon as possible. Indeed, to avoid that the detection has to be done by diagnosing AIDS, by having those opportunistic infections, which are a clear sign that there is an infection with the virus.
Yeah, it was more, do you see like a second-hand market where drugs are not accessible and maybe even how would I say, malaficious organizations jumping on
I'm not the expert on that. I suppose, like for antibiotics, there must be a parallel market with those drugs, and there must be, unfortunately, fake. Sam, maybe you know more about that. No? No. I don't know. But I'm sure there are some fake. And there are also some beliefs that if you take some plants and things like that, you will be treated efficiently as well. Okay. Thank you.
Okay, thank you. I will conclude the meetup with explaining a little bit the state of the HIV hack, and then we can go have pizza all together. So these were the 3 phases we defined for the project. So we are currently in phase 1. That's why we're having these meetups right now. And then the hackathon is going to be end of September. And then if we have good solutions, we would like to implement them in the countries to really have an impact with what we developed. So you all saw the hackathon kits. This is a document that regroups the use cases we defined to try to focus the efforts for this problem. So we have 8 use cases with 3 types of challenges. So it's modeling, visualization, and the last one, which is text mining, because we want to analyze the guidelines of the countries and see if we can find information in what countries decided to implement and the drug resistance. We have 8 open data portals that we want to use and 9 data sources. So data sources are just online data available, but not through a portal and an API. So these are 2 projects we initiated for the hackathon, the HIV Hack Meta Portal and then an HIV Organizations Network. For the first one, the goal is actually to allow hackathonians to explore new ideas quickly. So if we propose people to switch between 8 portals to learn the API and check everywhere if they have the data they're looking for, they're not going to go really far. So we really want one single entry point where if people want to include, for example, road infrastructure infrastructure and check quickly if they have access to those data. They just enter it, check if it exists. If it does, they download it. If it doesn't, they go on to the next idea. And this way we hope to have a quick prototyping and better solutions at the end. So how do we do this? The idea is to download do manually all the API translation, download the metadata from all these portals, and keep it on the server, and then we'll query it basically like Google would do. And if there is a data set, we have the connection to download the data. This is an open project. We have Fernando here that also is helping us with it. So if anybody here would like to give a hand on the project, feel free to find me afterwards and discuss the onboarding. For the second project, this is a bit born from, as Marie-Pierre said, that people acting on the ground, doing work with HIV. There's a lot of organizations, and we don't always know who they are and how they are linked, right? So we want to find a way to build at least a starting point of who is doing something. So this is like a first attempt to build a network of HIV organizations. So it includes scraping the websites. We go on HIV websites we know are organizations that do HIV. Then we follow the links to other websites, and we're building a model right now to classify whether or not it's an HIV website or not. So I have Haroon here helping me with the machine learning for this project. So as the same for the MetaProton, if someone wants to lend a hand, welcome. And then the goal also, if we have good results, is to actually do social analytics on it, to find what are the big organizations that have influence in certain areas. So this way we can further the impact. If we have solutions, we know who to contact. And it's also, both tools are actually valuable outside of the HIV hack itself. If we have a MetaProton working well, any company doing work with open data could use it. Same thing for the HIV organization network. So, voila. If you have any other ideas, comments on these projects and on the presentations, then we can talk about this around pizzas that are being first. Thank you.
A mindless sort of reaction, a nasty sort of contraction. You never get no satisfaction. But there's a big bad point that you seem to be missing, and it's driving you to destruction. But doesn't seem to stop you in belief. All this obsession got you going on that. Week after week, day after day, hour after hour, long way you came, one more to say, yeah, yeah. Thank you.